Thank you so much, LJ. It's my pleasure and honor to present at this wonderful conference. I'd like to thank David and Leah and you, as well as Tricia, for inviting me to speak. What I'm going to be covering today is the difficult area of behavioral symptoms in dementia and how we get our work that is in what I call the ivory tower or universities out into the real world. And I'll be talking specifically about two things that we have created to help with these issues, and that's the DICE approach and the WeCare advisor. And oops. Just briefly, I'd like to acknowledge the research that went into this work, and these are both research grants that we have received over the years that cover the work that I'm going to be talking about. My close collaborators, both in the area of dementia care, Laura Gitlin and Konstantin Laketsos, as well as work that has been done on the medications that we commonly use for dementia. I'd also like to acknowledge work that we did in Michigan that has to do with the two approaches. Very importantly, I would like to state that I have no financial share in any of the commercialization of these approaches. Any monies that we receive from commercializing these approaches are going to go back into the approaches to make them better and better for people with dementia and caregivers. So the topics I'm going to cover today are really what prevents people from people with dementia and their families from living well, which we now believe is the goal for people with dementia. We know that behavioral and psychological symptoms are among the most difficult aspects of living with dementia on a day-to-day basis. And part of that is because despite the efforts of wonderful organizations like the Alzheimer's Association and other resources, they are largely not coordinated in our country. And currently, we have a lack of personalization and precision in our current dementia care. We also have a workforce that in many places is largely without specialized training. So the approaches I'll be talking about again are the DICE approach, which we've created, and a tool that incorporates the DICE approach called the WeCare advisor. The other piece that I definitely want to touch upon today that LJ just touched upon in his introduction is the impact of the pandemic, which clearly has impacted everyone, but unfortunately has also really hit our older adults and those with dementia. So I definitely can't go without talking about that. So currently we have over 5 million people in the United States with dementia, and we have over 15 million family caregivers. And unfortunately, those family caregivers often find themselves navigating this difficult illness without resources or training. And I think that often we in the medical field, that is physicians, think of dementia, the syndrome and all of the illnesses that are encompassed by dementia as a medical illness. But I think all of us today know that dementia has many spheres, and those spheres include legal aspects, financial aspects, social aspects, and functional aspects. And these are all of the spheres that our families and people with dementia need to navigate. I like this picture of the many roles of the family caregiver because it really hits home how multidisciplinary or multidimensional the role of the family caregiver is. They are all of these things and more. So advocate, nurse, counselor, helper, chef, companion, keeper of safety, keeper of fun. And so people that are family caregivers, those 15 million people, are doing all of these roles and more. And for me as a physician, what is so important is the family caregiver is really the linchpin of care. So the family caregiver is assessing and reporting on symptoms, they're carrying out recommendations, and then they're coming back and telling me what the effect of those recommendations were. And we know that for family caregivers, managing behavioral symptoms is one of the most challenging aspects of dementia care. We also know from research that caregivers of people with behavioral symptoms are themselves more distressed and more depressed than those who are not managing behaviors. And we believe that caregiver distress may actually drive outcomes for many people with dementia. So it's a very interesting triangle that we have here, which is that we're not only dealing with the person with dementia, but we're dealing with the caregiver. And there's a lot of bidirectionality within that triangle. Again, we know that this is affecting many people. And of course, with the aging of the population, that is only going to rise. Projected that the number of people with dementia in the US may be 16 million by 2050. Now, I'll just take a second to say that some of that is being mitigated. That's some good news that we have, in that as we improve underlying conditions like hypertension and heart disease, there's some evidence that the incidence of dementia may be less than those projections had predicted. And so one of our goals of the Lancet Commission that I'm on is to look at preventable causes of dementia and start to hack away at those so that we can decrease risk for people with dementia. Nonetheless, the numbers will still increase. We know that cognitive impairment is the clinical hallmark. So most people in the public think about dementia as a memory illness. But I always like to teach our fellows and our residents that your memory isn't what gets you into trouble often in dementia. It isn't what gets you into a nursing home. It tends to be behavioral and functional disturbances. And those are nearly universal in dementia. So studies have shown that behavioral and psychological symptoms are almost universal. Over 98% of people with dementia will experience a behavioral or psychological difficulty at some time during the disease course. And often we find that it is those symptoms that dominate the disease course. So they either bring a person to treatment or they cause poor outcomes. And here are some of the behaviors that we often think about: depression, anxiety, apathy, psychosis, such as hearing voices or being paranoid, agitation and aggression, and many more. And I say and many more because some of the most problematic behaviors in dementia are actually not well categorized in thinking about them in this syndromal way about depression, anxiety, and so forth. They may be things like asking the same questions again and again, or wandering, or sexual disinhibition. And so many of these behaviors aren't necessarily well categorized, but nonetheless create many problems for people living with dementia and their caregivers. And what are some of the poor outcomes? Research has shown us that people with behavioral difficulties at the same level of cognitive problems have greater functional impairment. So they can do less in their ADLs and IADLs than people without those difficulties at the same cognitive level. They also worsen quality of life. They contribute to excess morbidity and hospitalizations. There is sort of a tongue twister called potentially preventable hospitalizations. And those are hospitalizations that we should be able to prevent if we give somebody good outpatient care. But we find that people with dementia often are hospitalized for things like urinary tract infections because the behaviors may have gotten in the way of treating those as an outpatient. We have also done research back when I was at Michigan that showed that people with behavioral difficulties tend to be placed in nursing homes earlier than those without those difficulties. So again, it's not necessarily your cognition that gets you into a nursing home, but behavioral difficulties. We also know that behaviors are a major source of caregiver burden and actually reducing caregiver income. So caregivers need to take time off work or deal with the behavior, bringing somebody in to see a physician, and thus get in the way of the caregiver earning a living. And part of this is because our caregivers now, many of them are sandwiched between taking care of an older individual and then also taking care of younger individuals like children or grandchildren. And so this becomes problematic. A study that was done about a decade ago showed that behavioral difficulties contribute to about $10,000 a year in additional care costs for people with dementia. And I would reason to guess that that number is even higher now. There's more recent research from my colleagues at Johns Hopkins that people with behavioral difficulties have a shorter time to severe dementia. In other words, it seems to hasten progression, and behaviors may even accelerate mortality, so hasten death. And so a colleague of mine basically has created the shorthand for all of this, that these behavioral issues are bad for people with dementia and their caregivers because they lead to all of these difficulties. So I like to think about things in terms of simplicity and problem solving. And so I've divided the issues that we have facing us with behavioral problems and dementia in terms of three big problems. And the first of that is currently in our country, caregivers are unable to access relevant resources exactly when they need them. We know that there are too few specialists. For example, I am a geriatric psychiatrist, as mentioned. There's fewer than 1,200 geriatric psychiatrists in our whole country. So a colleague of mine likes to note that we are actually more endangered than Bengal tigers. There's fewer of us than that endangered species. And so we know that we will never perhaps train enough specialists to actually treat all the people we need to treat. Therefore, we tend to shift our thinking toward training primary care physicians. Our primary care physicians often have very little training in treating dementia, and the training they have may be focused on the memory drugs that we currently have, which are largely pretty ineffective. And so that too becomes a problem. As I said before, dementia is more than a medical illness. So even if we were able to train up all of our primary care physicians, there's so many other spheres that this impacts: the legal, the financial, the functional, and the social. And so we need a larger solution. We know that resources are available, but it can be hard for our caregivers to find and access them. One thing that is very poignant, we did a lot of focus work that I'll be talking about later when we created the WeCare advisor. And one thing that was very poignant is we heard from a lot of caregivers that they got a diagnosis from a primary care physician and that was it. They didn't get any more resources or referrals. And this becomes a problem if people are not near our cities or academic centers. If they're in far-flung areas, for example, in Michigan, we have the Upper Peninsula, there's very little there for them to connect to. And so this big problem number one is connecting to resources when we need them. And if we think about how this lack of resources impacts caregivers and people with dementia, we can think about it in terms of the caregiver themselves. This contributes to stress, which we know is significant in caregivers, to caregiver burden, to depression in the caregivers themselves, to burnout, which may be associated with nursing home placement, and then to that lost income that I talked about. To the person with dementia, that creates unoptimized health and function, limited social engagement, which is even more critical right now during the pandemic, and a lack of activities that are actually tailored to the interests and likes of that person with dementia. Within the caregiver person with dementia dyad, this lack of resources can contribute to the following. The first is something that I often see in the office, which is a lack of understanding about dementia. So the caregiver that comes to dementia and is not trained in what dementia is as a brain illness may often say to me, "Dad is doing this to me on purpose. he's always been ornery, and now with this dementia, he's even more stubborn and difficult. And so there's a lack of understanding that this is actually coming from a brain illness. This can also lead to poor and negative communications. And studies have shown that those negative communications, yelling, being overly negative or pejorative in your terms, can actually lead to worsening for the person with dementia. And lastly, if somebody as a caregiver doesn't understand the stages of dementia, they may be expecting too much from the person at that person's dementia stage. So the person with dementia may be in a moderate to severe stage, but the person who's caring for them may still be treating them as if they're in a mild stage. And so that's very important in thinking about resources and education. Big problem number two, in medicine now, we talk a lot about both personalized medicine and precision medicine, and both of those are very important. I think we all want to get treatment that is tailored to us as an individual. And to just do a little self-disclosure, I actually just had a hip replacement and I'm 55. And so hopefully the rehab and treatment that I've gotten has been tailored to me as a 55-year-old as opposed to a 75-year-old who may have gotten a hip replacement. And that has contributed to faster rehab for me and my ability to actually give you this talk today, 2.5 weeks after my hip replacement. So I think this is important to all of us and should be important to us in our care for people with dementia as well. People with dementia also need personalized and precise medicine. So what do those terms actually mean? They're often used interchangeably and kind of confused. So again, to get us all on the same page, personalized medicine is treatment that focuses on patients based on their individual clinical characteristics. So again, with my hip replacement, that was focused on the fact that I am 55. I can probably do some things differently than a 75-year-old and maybe able to move through rehab faster. For the 75-year-old, we may need to make those rehab exercises more gentle or have them progress more slowly through rehab or use more pain medication, whatever may be the indication. Now, what is precision medicine? That focuses on which treatment approaches will be effective for which patients. So again, looking at my hip replacement, the type of hip replacement they did for me was tailored to somebody like me who's at my age, as opposed to somebody who's 75. So again, we're choosing the treatment approach based on which patient we are treating. And sadly, when we look at dementia care currently, it is neither personalized nor precise largely. Given that there is a lack of cure for dementia, the current focus is on day-to-day management, and much of that, of course, is focused on behavior. But I will talk about in a minute how our current real-world care, whether in the community or in nursing homes, is largely focused on medicating or sedating people with dementia for their behaviors in a non-tailored way. And I'll talk more about that in a minute. So let's talk about how this differs when we think about the precise and personalized way that physical symptoms are treated versus behavioral symptoms. So let's say that a family caregiver is dealing with a physical symptom and they call up their doctor and they say, Joe, whom they're taking care of, has shortness of breath. Does the doctor say to them, oh, okay, I'll write for an antibiotic right now, just assuming that this is some type of infection? Absolutely not. The care is personalized and precise, and the caregiver talks to the doctor about, this is hard to see, but it's just meant to tell you, this is the type of algorithm that a physician thinks about when they're dealing with shortness of breath, because shortness of breath could actually be an infection. It could represent a pulmonary embolus. It could represent COPD. It could represent heart disease like heart failure. And so the doctor has to go through this complex algorithm to figure out what is going on with the patient when they hear shortness of breath. The doctor does not just jump to a medication to treat it, but actually goes through an entire history, laboratory work, physical exam, and so forth. Now, how does that differ when we're dealing with behavioral symptoms? Caregiver dealing with a behavior will call up a physician and say something like, Joe is agitated. And agitation is one of my least favorite words because I don't know what it means. But we often use it as if that's a diagnosis, and it's not. Or the caregiver may be even more directive. Doctor, I need something to calm Joe down. And that something is medications. Or what I may hear from a nurse at 5 o'clock on a Friday is, I need an order for Risperdal, 0.5 milligrams BID right now. So again, how does this differ from how we're dealing with the physical symptom? We're going straight to the treatment without any examination of underlying causes. And so what happens is that the physician then responds with something like, I'll write for the Risperdal right now. Or if they're really concerned, I'm sorry, I'm going to go back for a second. If they're really concerned about the effect of antipsychotics, they may write for an alternative that may be even less efficacious and equally sedating. And so the algorithm that we have right now looks like this. And I would say we can do a lot better in this field. Think about the algorithm that I just showed you for somebody dealing with a physical symptom, shortness of breath. Our algorithm stinks. We have agitation directly going to medication without any personalization, precision, or examination of any underlying causes. And again, we need to do better. So our big problem number 3 has to do with medications. And what you see on the right side of the slide is actually an advertisement from the American Journal of Psychiatry in the 1950s. And it was actually a 2-page ad. So they took out a lot of ad space. And they showed Grandpa here with his cane, and he has what they're calling senile agitation. And they are prescribing Thorazine for that. And the other page that I don't have up here said, what are we going to do about Pop? And the answer was, we are going to give him some Thorazine. And so what I would say to you is, we are in the 21st century and we continue to treat people with medications as if we're in the 1950s. We're not using Thorazine anymore, but we're using its newer cousins like Risperdal and Zyprexa and others. And in most cases, medications are not treating the underlying problem, but we're covering it over. So let's say Pop is waving his cane, because if we actually did a thorough history and physical, we found out that he had a urinary tract infection. The Thorazine is not treating that. The Thorazine is just sedating him and covering over that symptom, but we're not treating his urinary tract infection. So that is really important when we think about the lack of personalization and precision. We also know, and I'll show you some data that we have from when I was at Michigan, that medications are associated with significant side effects, including mortality. And I'll also show you some data to show that efforts by our national policy bodies like CMS to decrease the use of one medication class, antipsychotics, have actually driven up the use of others, such as anticonvulsants. So it's not that we are using less medications, we're just pushing use into other classes of medications. We know, and I'll show you data from this, that behavioral and environmental treatment strategies, if selected appropriately, which is precision medicine, are actually more effective than medications, but there are reasons that they are not chosen. So let me go through this in a little more detail. What is the risk of medications? This is work that we did at Michigan a couple of years ago, and I'll orient you to what we're looking at. It's a bit scientific, but bear with me. So up here we have the number needed to harm. And the number needed to harm, abbreviated as NNH, is the number of people you need to treat with the medication to cause one death. And so in medicine, we want the number needed to harm to be as high as possible. So we want to be able to treat a lot of people with no deaths. And if you look at the number needed to harm for antipsychotics, unfortunately, it is low. So you only need to treat eight people with dementia with haloperidol to result in one death. It's a bit better for the newer antipsychotics. Olanzapine, the number needed to harm is 14. For quetiapine, the number needed to harm is 31. For Risperdal, it's 16. And so again, that number is pretty low. Now, what about valproic acid? That's something people often use, the trade name for that is Depakote. People often use that saying, oh, well, I don't want to use an antipsychotic. I'll use something else to calm the person down. Unfortunately, the number needed to harm for Depakote is 20. So you only need to treat 20 people to result in one death. So unfortunately, with medications, there is a significant mortality risk associated with many of them. And that is not to say that as a geriatric psychiatrist, I don't use medications. I'll be talking to you about when it is appropriate to use medications, but that's just to say this needs to be in the back of our mind that there is no free lunch here. We can't sedate people without incurring risk. And there's many more risks than the mortality risk, but this is a really big one that we need to be concerned about. So I mentioned before that antipsychotic use has declined. CMS has put on a big push over the last decade to reduce the use of antipsychotics in nursing homes. However, we wondered, and we started doing this research a number of years ago, would there be unintended consequences of these policies of CMS? And what we showed is that there's a shift to other psychotropics with even less benefit, less evidence of benefit, and similar risks. So as you see here at the top line, this is psychotropic use overall from 2009 to 2014, and it has dropped a little bit. And a lot of this is the reduction of antipsychotics. However, if you look at the same time, what you will see is that there is a rise in the use of mood stabilizers like Depakote and gabapentin, and there's also a rise in the use of benzodiazepines like Ativan. And so what we're seeing is a movement from the use of antipsychotics to other medications. And unmeasured here are also medications that are used for sedation that we can't measure as well in large-scale claims data. And so some of those things might include things like Atarax, which may be used, Benadryl, sometimes the medications that are used for conditions like pathological laughing and crying are used in dementia as well. And we've seen an upsurge in those as well. So it's not that we're using less medications with the CMS push, we're just shifting them to other types of classes. I just wanted to take a minute to talk about something that we showed most recently a couple months ago, again, with my junior colleague, Lauren Gerlach, and my colleague, Donovan Most at Michigan. We showed that the rise in mood stabilizer use is largely related to gabapentin. And so over the last period, we've seen a large rise in the use of gabapentin. And we think that that has to do with the fact that as antipsychotics have become more regulated, people have then bypassed that by using more mood stabilizers. And the growth of this is even larger than the declines in antipsychotic use. And again, the majority of it is gabapentin, over 70%. And unfortunately, in the literature, there is largely little evidence to support the use of gabapentin for behavioral symptoms. what that gabapentin is likely doing is making the person sleepy and so less able to do those behaviors, but again, not treating any underlying causes. We know that gabapentin is routinely prescribed off-label for anxiety, insomnia, and agitation. A large number of these patients may also have chronic pain. However, again, for chronic pain, there's little evidence of efficacy for this indication. So again, the rise of gabapentin to get around the antipsychotic regulations. So I'm going to ask something provocative. We use a lot of medication in the community and long-term care. I want you to think about, as I go through the next few slides after what I tell you, does medicating behaviors actually make sense? I want you to think about that. This is a conceptual model that we created a couple of years ago and has been very useful, so much so that the NIH has seen fit to endorse it in a panel that was held a couple of years ago. And we also recently published an update on this model last year in JAMDA. I'm going to unpack the model for you and also go through it much more slowly. But what the model actually talks about is where behaviors come from. Why do we see this universality of difficult behaviors in dementia? And as just a moment, I'm going to say that a lot of people have issue with even the term behavior in dementia, some dementia advocates, and I would say, unfortunately, there's not any better term currently. And I would just say that behavior is an expression of need. We all have behavior, and people with dementia are no different. And why we use the term difficult behavior is because eventually those behaviors get medicated often. And so it is a way to classify, and there may be questions about that during the panel or during my Q&A. I'm happy to talk more about that. But to get back to the model, at the basis of behavioral issues is the neurodegeneration we see associated with dementia. And that may cause behavioral issues in two ways. The first is by disrupting brain circuits directly. And a great example of that is apathy. A number of researchers have actually been able to highlight certain brain circuits that are disrupted in people with apathy. And so that may be sort of a direct link. So neurodegeneration leads to a disruption in brain circuitry, and that leads to a behavior like apathy. Up here, just as an aside, we have some modifiers, which there may be some genes that certain people are blessed with that actually cause fewer behaviors when they have dementia. People may have more cognitive reserve. That may also be a modifier, including resilience. Comorbidities may weigh in, and medication use to increase behaviors. And then here is just some of the circuits that are involved in behavioral issues, including the limbic system and our circadian system. And then these are some of the impacts of this disruption in brain circuitry. But again, all of this just to simplify to say that behaviors can be caused directly by disruptions in brain circuitry. The second way, which is probably an even more important way, is that neurodegeneration leads the person with dementia to be more vulnerable to stressors and triggers. So in essence, it removes the ability of the person to withstand certain stressors or triggers, and that leads to behaviors. And what are some of those stressors and triggers that occur in people with dementia? We've boxed them into three categories, and these are sort of our dementia triangle: the patient, the caregiver, and the often ignored actor, the environment. So within the patient, a behavior may be triggered by an acute medical illness. I had a patient that every time she got a UTI, she became psychotic. So again, the UTI was heightening her vulnerability to express that as a psychosis. Certain people may express behavior with pain. I had a patient that came in and his daughter was extremely exasperated with him, saying that He was just extraordinarily stubborn. He was refusing to get in the car. He was resisting her, trying to get to the appointment. And I noticed that as he was sitting in the appointment, he kept rubbing his shoulder. And eventually I did a physical examination on him, and he had a lot of resistance to moving his shoulder and a lot of facial expression denoting possible pain. We went and we got an x-ray. It turned out he had a rotator cuff tear. And so again, we could have just medicated that and said, oh, he's an ornery old guy, you know, we're going to give him an antipsychotic. We would have missed the underlying cause, which was pain. We may also have people who have a premorbid personality disorder. And so that's something that we should think about as we deal with somebody with dementia. Just because they develop dementia doesn't mean that goes away. It may become modified in certain ways, but we should consider it. Similarly, if somebody has a premorbid psychiatric disorder, like they had schizophrenia in earlier life, the development of dementia doesn't mean that the schizophrenia goes away, but that we have to incorporate it into our planning. There also may be unmet needs. So things like fatigue, poor sleep, hunger, fear, or boredom, those can all lead to behavioral issues. So those are all within the patient. Now, what about within the caregiver? The caregiver themselves may be distressed, depressed, or fatigued. And one of the things we see in the dyad is if the caregiver becomes depressed, that may become mirrored in the person with dementia. So even though this is something that is going on within the caregiver, there's that mirroring or bidirectionality that occurs in the dyad. The person with who is the caregiver may feel a loss of mastery and frustration. They may have communication challenges. We talked earlier about negative communication or unrealistic expectations. They also may have a style, and this is something one of my mentees is studying, that akin to parenting styles makes it difficult for them to manage behavior. They may have limited resources, so they may not have a good support network, or they may have financial constraints, and all of those may add up to increase vulnerability to behaviors in the person with dementia. Lastly, the environment is really key. And again, often we ignore this. I often think about a nursing home that I visited, and there was a woman in a geriatric chair, and she was sitting by the nurse's station, and the geriatric chair was cranked up so that she couldn't get out of it. Her feet were higher than her head, and she was calling help repeatedly, and everybody was just ignoring her, going about the routine, because she had just continued to do this. And I looked around and I tried to think about, from her perspective, what she was seeing. There was absolutely nothing in the environment to look at, nothing of interest, and she was strapped in this jerry chair. And her response was actually a pretty rational one. I think if I had dementia and I was in that position, I would yell help as well. And so we need to think about the environment that somebody with dementia is in. And there may be understimulation, as the place that I described, or there may be overstimulation. There are places that I've gone to with so many people going back and forth, clutter and other problems. And so that needs to be thought about as well. There may be safety issues in the environment. So the house has not been dementia proofed, and the person is at risk from that. There may be a lack of activity or structure, and we'll talk a little bit more about that in a minute. There may be limited light exposure. This is one area that I'm looking at with a colleague of mine from Rensselaer Polytechnic, that people, whether they're at home or in a facility, often get less than 30% of the natural light they should be getting per day to regulate their circadian rhythms. And those circadian rhythms are so important for sleep and mood and many other aspects of our daily functioning. And so light exposure, natural light exposure, is very important. There may be other factors that have to do with the type of neighborhood they live in. There may be are real with regard to crime. So again, all of these factors highlight that there's no one size fits all solution for behavioral issues. There's no one medication that we're going to come up with that's going to be a magic bullet, because it couldn't possibly deal with all of these factors. And so that's where we need to think about personalization and precision. So let's talk a minute about neurodegeneration. Here we see in Alzheimer's disease, the plaques and tangles that occur. Again, we can have that direct impact to brain circuitry, with apathy being a good example. Or we may have this indirect effect, which changes the ability of the person with dementia to interact with others in their environment. And I've often showed this picture to groups and said, what medication treats the sort of hoarding, disarray, and difficulty we see in this picture? There's no medication, but one man yelled something that still makes me laugh, which was kerosene. He would burn the place down, and we don't want to do that. But this is to say, there's no medication that, if one of these folks had dementia, would treat what they were dealing with in their home environment. So we need to think about environmental factors. Again, person with dementia factors, let's think about psychiatric problems or personality issues from earlier life, which include schizophrenia, bipolar disorder, anxiety, depression, personality disorders. Let's make sure treatment is maximized and tailored. They may not need the same level of medications they had earlier in life. I've had people with bipolar disorder that, as they age, I've needed to taper their medications back because of the way their organs now process medication. But this is very important. We don't stop treating them because they have dementia. They may have acute medical problems. I mentioned infection before, but even things like constipation can have an impact, dehydration, and of course, medication interaction. So always knowing if there was a new medication that's concurrent with the behavior, that may be something to take a look at. I mentioned unmet needs. We should always be thinking about these: pain, sleep problems, fear, boredom, loss of control or purpose. Again, with the caregiver, let's think about stress, burden, and depression. A lack of understanding of dementia. This is where the Alzheimer's Association is so important, because of the kind of education that they do with people with dementia, both not only in terms of educational resources, but the kind of education that goes on among peers and support groups, that we need to understand how the brain disease impacts behavior. How we communicate. A lot of our work with caregivers is talking about communication and about leading, aligning our expectations with dementia stage. Again, with the environment, we can have an environment where people will often leave a person with dementia in front of a blaring TV or stereo that may actually escalate behaviors. We may have an environment that's very chaotic, with a lot of people coming and going. I had one patient that, when there were a lot of people in the house, we allowed her to take a time out and go to her room so that she could kind of de-escalate and calm by herself in a quieter environment. There may be, as I talked about with the nursing home, a lack of stimulation, with nothing to look at or enjoy. And importantly, a lot of activities that are done in group settings are not tailored to the individual. So I once visited a nursing home, and they were doing an activity with reminiscence that was not holding the attention of a number of people. And as those people got up to leave the group because they weren't interested, they were actually forced physically back into the group. And clearly that's not the kind of dynamic we want to be having with activities. And lastly, often we may, in the community and with caregivers, have a lack of structure or routine, so that the person with dementia doesn't know what to expect from day to day. And that's really important. So our structure and routine can help somebody to have less anxiety about what is going to be happening. So I'm going to show you a video, and hopefully via the Q&A section of the talk, I want all of you to consider what might be some of the triggers for the person with dementia in this video. So again, watch it with an eye to those boxes at the bottom of the chart that I showed you, and what might be some of the triggers we're seeing that may be escalating his behaviors. And hopefully I'll be able to see those in our chat function. So I'm going to play the video now. Are we hearing that? Because I'm not hearing that. Leah? It looks like there's no sound, so I'm going to stop. Oops. Does anybody know how we can get the sound on for the video?
Hold on, I'm working on it right now.
Okay. We'll just take a pause here.
Frank, you haven't touched your lunch.
I already ate.
No, you didn't. You didn't eat a thing. Now I want you
Leave me
to...
alone.
Frank, you have to eat.
I've eaten.
Frank, your pills. You haven't taken your pills.
Go away! Those aren't my pills! What are you trying to do to me?
You have got to take your pills now and eat your lunch. What is the matter with
I'm
you?
leaving.
What?
Get in the car! Where's the car?
No, you don't. You are going to take these pills, you are going to eat your lunch, and you are going to take your bath. What is the matter with you?
Okay, so if people could go to the Q&A and volunteer some triggers that they see, that would be awesome. And I will pause so you can do that, or maybe people are doing it in the chat. Do we want to do this in the Q&A, Leah?
Yes, the Q&A.
So people could use the Q&A and tell me what they saw with this couple. What might be contributing to, clearly he escalated from sort of sitting in the chair to all of a sudden, you know, throwing the tray. So a number of people have talked about the caregiver. We're getting some great answers, and I'm just going to read those back to you. Her approach, she approaches him in an aggressive way. She's sort of telling him what to do. She's frustrated. Her tone is demanding and contentious. This is a great one. Lauren mentions possible pain. And I think what she is seeing is that Frank is kind of holding his side on the left there. So that's curious. Another person mentioned she doesn't ask why he's not eating. He was left alone. She is forcing him to do multiple things. That's excellent. She, as opposed to focusing on one thing, she's talking about eating, taking the pills, doing a bath. That's a lot for him to process, I think. Another person mentioned she's not more empathetic. She's not empathetic. Her communication is negative. She's not following his reality. Her tone, she's not calm. She's talking at him rather than with him. This is a really good one. Someone mentioned that she kind of didn't go in front of him and sort of say pleasantly hi to get his attention and sort of start from there greeting him. Another person mentions leaving him to eat by himself, that it might be better to eat with him. There's a lack of socialization. She appears overwhelmed. You guys did great. This is fantastic. I don't know that I have a lot more, but I think you're right. From the jump, she appears very frustrated and upset. And I would be worried about this caregiver and her level of anxiety. And what you can see here is that her attempt to speed things along actually makes things worse. And that's why teaching caregivers how to communicate is so important. So you guys did awesome. Okay, so I showed you this slide, which was our model, and at the bottom, all of these stressors and triggers. And I just wanted to take a minute to talk about what we're dealing with currently in the pandemic and how this has made things even more difficult. And so some of the things, and you all probably can come up with even more things, from your experiences, but some of the things that I see folks dealing with is that COVID and the pandemic has disrupted regular clinical services. I was on a national call the other day, and people mentioned that many places, nursing homes, haven't been able to get together their technology to actually bring doctors, social workers, and psychologists and psychiatrists in to help people with dementia. And so that is a real issue. And hopefully, as the pandemic goes on, I was so excited to see LJ's slide, which included a response to COVID, because this is something that I think we really have to do for our people with dementia and their caregivers. We also see in our older adults, my parents are both 85, and they definitely have this, an increased anxiety due to being in a high-risk group. So every day, my parents are watching the news and being told that they're in a high-risk group. And so, of course, that heightens their anxiety about if they get the illness and what will happen to them. This has also disrupted our social routines such that my husband's grandmother, who's 102, has received no visitors in Idaho during the pandemic. And so all her visits with family have been via Zoom and things like, chat on different social media, but she hasn't been able to see any family because of the worry and the real worry of spread of COVID in the nursing home. So clearly this has disrupted our social routines. People are much more isolated, obviously not being able to see friends. They've lost their outlets and activities. So going to respite, getting daycare, senior centers, going to church. My church has opened and reopened, I think, 3 times during the pandemic, and tried to respond, but now largely is via Zoom. So again, we've sort of lost that social contact. And we also see losses in the actual peer group due to the virus. So that's very scary for people with dementia. And so I think one of the things we have to think about in the pandemic, and again, I was so excited to see the Hawaii Alzheimer's Association's response to this, is the use of technology to counter many of these issues. So I think that's really, really important. So given all that I just mentioned, I want to get back to my question, which was, does how we largely treat behaviors now currently make sense, that we have all these medications on the right and all the things I just talked about? Do those actually treat the majority of these issues? No, they actually don't. And the evidence shows that. And I'll talk about that in a minute. But largely what we are doing with medications, and I'm not saying there isn't a place for this, but we're sedating people. But we should know that we're not actually treating their behavior. And so that's really important. So if medications aren't treating behavior, what could we be doing? And the answer to that is non-pharmacologic treatment, which is a really crappy term, but kind of have to stick with it, because the alternative, which is eco-biopsychosocial, which I've tried to get to stick, is just too long and unwieldy. But nonetheless, these types of treatments, which are either in our environment, psychological, social, or sometimes biological, should actually be first line. And all of our expert bodies, whether it's the American Medical Association, the Psychiatric Association, the Psychological Association, recommend these first line, but largely they don't get translated into real world settings. And we think that's because there's a lack of scalable training programs for caregivers and providers. These interventions require more time, and in our current climate, that's not incentivized. It's much easier in my chart to, click a medication, and you can do that in less than a minute, whereas the time required to do some of these approaches may be longer. There's actually also a lack of guidelines, so people don't know what strategy to use and when. And there's so many interventions. We know about acupuncture and music therapy and reminiscence and many more. What actually works and what doesn't? So our big problem number 3 is that caregivers and providers are largely lacking in training on how to use proven non-pharmacologic strategies to manage behavioral symptoms. Just a word about efficacy. This is from Henry Brodety, who is from Australia. His meta-analysis of 23 randomized control trials of family caregivers using non-pharmacologic interventions. And what he found, the outcomes were related to the frequency and severity of behaviors and caregiver well-being, that the effect size of these non-medication approaches was actually larger than that of medications used for behavior and dementia, like antipsychotics, but also larger than the effect size of memory medications for cognitive symptoms. So what's really important to underscore is that if we do these interventions with family caregivers well, they actually work. Now, the trick is, how do we package those so that we can use those with family caregivers? Again, this is our best evidence, family caregiver approaches that train family caregivers to use problem-solving skills to manage behaviors, to increase tailored activities for people with dementia, to improve and enhance communication in the person with dementia caregiver dyad, reduce environmental complexity, and simplify tasks for the person with dementia so that they are at the level of their dementia stage. So the best evidence we have is for this type of caregiver intervention. So again, to just summarize the 3 big problems: the inability to access relevant resources when needed, that current dementia care is neither personalized nor precise, and that we currently lack training among caregivers and providers on how to use proven non-pharmacologic strategies to manage behavioral symptoms. So how can we solve big problems 1, 2, and 3? And what we thought about when I was at Michigan, and continue to think about now that I'm at UC Davis, is that we do that using innovation, packaging, and technology. And so what we did in 2011 was we organized a meeting of national experts across disciplines. So this included people from geriatric psychiatry, geriatric medicine, pharmacy, social work, nursing, psychology, and I believe we also had several behavioral scientists, to consider the etiologies of behavior, ways we could include the caregiver in the process, how we could integrate both using medications and non-pharmacologic strategies, because what we found as we talked was that largely doctors were thinking one way, and providers in other specialties like even physical therapy, social work, psychology, were thinking another way. And those 2 approaches didn't tend to be integrated. We wanted to build in flexibility to use the approach in various care settings. And the whole goal was to avoid knee-jerk prescribing without any assessment of underlying causes. And that's what I mean when I talk about the lack of an algorithm, the lack of precision. When somebody says agitation and they say, oh, Risperdal, we want to avoid that. We want to think more cleverly and complexly. I don't know if complexly is a word, but with complexity, how's that? And importantly, we need to package this. Packaging is important. Think about all the things we like in the world, like iPhones and things like that. They're packaged nicely. People use things that are packaged nicely. Otherwise, it's too complex. The algorithm that I showed you earlier is way too complex. It's scientific stuff that we need to think about in the ivory tower. But as we take that out into the real world, we need to package it better so that people can understand it and, more importantly, use it on a day-to-day basis. So what we ended up with was what we call the DICE approach. And DICE stands for four things: describe, investigate, create, and evaluate. So what is describe? And I'll go through these in much more detail, but we want to describe the behavior that challenges in full detail. Agitation is not enough. I don't know what to do with that. I want to know who's involved, what happened, where it happened, when it happened, and how it happened. That's really important to get to the next step of understanding what might be causing it. As we investigate, we want to think like a detective and explore causes that could be occurring within the person with dementia, their caregiver, or the environment for possible clues at what might be triggering that behavior. We then want to create a prescription that's not necessarily medication, but a prescription for strategies that collaborate with whoever is involved. So if it's a family caregiver and a physical therapist, a family caregiver and a home nurse. And we also want to include the person with dementia's perspective. And that's very important for collaboration as well. And we want to think about preventing and managing behaviors. And lastly, and importantly, we want to evaluate, just as we would for a medication. If we try something in the home or in a nursing home, we want to look at what we did, how effective it was, whether we fully implemented it, and whether we should modify it or do something different the next time. So these are the 4 steps of the DICE approach. How does DICE differ from other approaches to behaviors out there? The first is that it's algorithmic. We designed it to be easy to remember and develop good habits. So physicians like things that are easy to remember. For example, if we say, if we're teaching medical students, what are the symptoms of depression? We all learn SIGI caps. If we're learning, and my daughter's in medical school in anatomy right now, if we're learning the cranial nerves, there's a kind of body mnemonic that goes with that, which I'm not going to tell you what it is, but it helps you to remember the cranial nerves. We also want to integrate medical and non-medical approaches, and we want to think about medications for people with dementia beyond psychiatric medication for behaviors. So we want to think about things like pain, infection, constipation, and we want to tailor the strategies to the person with dementia, the caregiver, and the environment. So I'm going to take you through a real life case using DICE to show you how this works. So this was a woman, the name has been changed, Gemma, who was 85 years old, a really delightful Italian woman. She emigrated from Italy 50 years ago. She was living in an assisted living facility. She was generally really good-natured, but she often got agitated in the afternoons, and she would ask the staff to go home, or she would say that she needed to get to church right away. In talking to the staff, they often tried to reason with her to calm her down, but Gemma would continue to escalate. She would start following the staff in her wheelchair with her little feet, repeatedly asking them to go home or to be taken to church. And they would get frustrated with her. She was interfering with their workflow. They felt that she just wouldn't listen to reason. And so they would often find themselves administering a PRN dose of an antipsychotic to her to get her to stop this behavior. And so if we go through the DICE approach with Gemma, first we want to describe the behavior. Again, we could just say she's agitated, but that wouldn't give us a full picture. So we really want an accurate description of what's going on. Again, if we said shortness of breath and we were doing a physical and getting a history, we would want to know things like, when does the shortness of breath occur? What makes it worse? What makes it better? Does it have a cough with it? We would be asking all kinds of questions. Same thing here. So the clinical scenario we're presented with is Gemma, an 85-year-old assisted living resident, gets agitated in the afternoon, and we want the caregivers to play it back to us like a scene in a movie. And the example I always give caregivers as the scene at the end of The Wizard of Oz, where the final confrontation occurs in the Wicked Witch's castle. And so if we were telling somebody about that, we could do it in shorthand like agitation, and we could say the Wicked Witch died and there was a happy ending. But that wouldn't really tell us what happened. So we want to know who was there. Well, it was the Wicked Witch, her flying monkeys, it was Dorothy, Toto, the Scarecrow, the Tin Man, and the Cowardly Lion. It was at the end of the movie. It was in her castle. And what happened? The Wicked Witch goes to set the Scarecrow on fire, and Dorothy gets a pail of water and it inadvertently hits the witch, causing her to scream, "I'm melting," and to melt into the floor, and all that's left is her hat. And so you can see that description that I just gave is a lot better than the Wicked Witch died. We know the who, when, where, and what. And that's the same thing we want to do with behavior. So let's do it with Gemma. For her part, she's asking to go home. She says, I have to get to church. Typically starts in the late afternoon. She begins to follow staff in her wheelchair. When we talk to staff, they try to reason with her. They give her reality. This is not your home. You live in a facility now, or we're not going to church right now. We have work to do. They feel that her behavior is interfering with their workflow. And in terms of the environment, there are group activities going on in the afternoon, but Gemma doesn't enjoy these and will often try to leave the group. So that's the full description of the behavior. Now let's start to investigate it. Investigate is another often left out step. We are led to it by the clues from describe. We play detective to search for underlying causes or triggers, and they often come from one of the three triangle categories: the person with dementia, the environment, or the caregiver. And these could include things like pain. In the earlier video where we saw Frank, he was holding part of his body. That's a clue for pain. We might also see fast breathing, groaning or moaning, pushing away when touched. For somebody with constipation, we could have pain on touching their stomach, or we might see pain when they're moving their bowels. For urinary tract infection, we may see burning pain on passing urine, urinating more frequently, cloudy urine. And medication changes are another one that we need to look at, either changes in long-standing medication in terms of dose or new medications. We often have anticholinergic medications added, like Benadryl or Ditropan for urinary issues. Those may cause behavioral issues. In terms of the caregiver, we want to look at how they're looking at behavior, if they're reacting harshly, offering too many choices, expecting too much, feeling stressed, anxious, or depressed themselves, or expectations that may be unique to that setting, either cultural or in the facility or in the family. And then we shouldn't leave out the environment. So let's investigate for Gemma. She had no prior psychiatric history, although her family, when we talked to them, stated that when she got anxious, she often in her early life would be very action-oriented. She'd clean or cook. She was a regular churchgoer all her life, attended Catholic Mass daily. She also ran a family restaurant, Italian family restaurant, for years, and loved to cook and talk about food, and loved Italian music from the 1940s, calling American music noise. So she did not like it. She used to say that many American activities are a waste of time. Why they exercise, they should do work instead. So think about the groups that Gemma might be asked to attend. those aren't a good match for her. The staff did not know much of Gemma's history, and they couldn't understand why she couldn't see that they were busy doing their work. They were frustrated that she wouldn't participate in the facility's group activities like music and exercise. Why won't she just go along with the program? And again, these daily groups were a mismatch for her interests and preferences. So now we go to the create stage, and there's 6 general strategies we can use to create solutions. These are managing any physical problems we find in the investigate phase, providing family and staff education and support, improving communication between the caregiver and the person with dementia, creating meaningful and tailored activities, simplifying tasks, and ensuring that the environment is safe. So what did we do for Gemma? Well, first we ruled out medical issues. She didn't have any of those going on. Importantly, a lot of our work was with staff. So educating them about behaviors and what we call the broken brain, that these behaviors often aren't something somebody is doing on purpose to make their work harder, but they are a manifestation of their dementia and this broken circuitry that they have. We reinforced communication strategies that were more effective. So their idea that reasoning with her would be effective, it wasn't working, but communication strategies that they could use more effectively. And the idea that taking some time to brainstorm tailored activities for her would actually save some time in the long run. So I'll talk about those in a minute. In terms of communication, we want them to redirect calmly and with humor. Sometimes they may even be able to incorporate her into their staff routine by giving her a job as time and work permitted. So in her environment, and this was probably the most important, was creating routines and activity for her that were safe, not overstimulating, and tailored to her interests, and importantly, starting them before she got agitated. So we know that she gets agitated in the late afternoon, starting those activities ahead of that to prevent the behavior, and incorporating into those activities her own interests. So she loves Italian food and music. She likes her religious practices. Playing her a record or putting on a video of something like a church service could be very useful. So trying some of those things like that. Also allowing her to wander safely when it's not harming herself or others can be useful, and then redirecting her calmly and with humor. So those worked very well with her. But importantly, we should not forget to evaluate. So we could use something as formal as an NPIQ, which is something that I use in clinical practice, which actually really formalizes this in terms of what is actually happening with symptoms. But probably for your purposes, you don't want something as complicated and clinical as that. And you might consider something like this, where we just rate the frequency and severity of a behavior on a scale of 0 to 4. And we rate that at the beginning before we do an intervention, and we rate that a week or 2 later after we've done an intervention to see what the impact has been. And if we see a reduction, we probably want to continue with that intervention. If we don't, we may either want to tweak the intervention or try something different. So again, with Gemma, we look at the effect of these non-pharmacologic strategies. With staff interventions, one thing that's always important is to see what staff actually tried, because sometimes we talk about an intervention, but they may not actually try it because they're resistant to it. And again, I'm not using the word resistant in a negative way. I'm saying it may not be something that worked with their workflow. So we may need to think about something different. We want to see what worked and what didn't, and if there were any unintended consequences noted. So did the behavior actually increase? If that's the case, we certainly don't want to do that intervention anymore. We want to try something different. So we want to look at changes that were made in the environment as well, new routines, and see what the impact was. What about the use of medications in the DICE approach? I told you that we integrate the pharmacologic and non-pharmacologic. And what I would say is that all medications used in dementia are off-label, None of those are approved by the FDA for anything in dementia and behavior. And off-label use of medication is not necessarily a bad thing, but the reason the FDA has not approved any of these medications for use in dementia is because the risks, side effects, and even death tends to outweigh the benefits. That our best efficacy is with the antipsychotics, and they have very modest efficacy at best and high risks. So they have not approved any of those. The DICE approach, importantly, does not prohibit the use of medications. But rather, what's important is that we carefully consider the risks and benefits in every case, and we use those very judiciously, and I'll talk to you about when. So we always assess safety as part of the describe step. Is anybody at risk from this behavior? Is the person with dementia at risk, or is the caregiver at risk? Is anybody in the environment at risk? If anyone's safety at risk, of course, we want to be involving the medical professional immediately. We use psychiatric medications as a safety measure, largely as first-line therapy in 3 specific cases in the DICE approach. This first one is major clinical depression with or without suicidal thoughts. And the reason for that is because that is a dangerous condition. Somebody might not be eating, somebody might not be sleeping, somebody might be suicidal, so we would medicate that. We would also use it if there is aggression with risk of harm to self or others. So if somebody is being so physically aggressive that we can't even do the DICE approach because we can't get labs or even get a blood pressure, it may be necessary to sedate somebody so that we can actually do those steps. And lastly, we would use it if somebody has psychosis with risk of harm to self or others. Now, why wouldn't I just say psychosis? The reason for that is that psychosis is not always experienced as dangerous. I have seen patients where psychosis was relatively benign. One example of that was a gentleman who was hallucinating a large array of Christmas ornaments on a wall in front of him. And this disturbed his family quite a bit because they said it wasn't normal. But when I asked the patient about it, he said he actually found it quite pleasant. So I wouldn't want to medicate that because all evidence shows that's probably a transient condition, and indeed with him it was. But we want to medicate psychosis when it causes harm. So if somebody is so paranoid that they're not eating, or they think their caregiver is trying to kill them, and therefore it's interfering with care, these are the 3 conditions that we want to use medications as first-line therapy. I also want to note that it is important, again, just because somebody has dementia, we don't stop medications if they have an underlying chronic mental illness. So if they have schizophrenia, that's another case where medications would likely be continued, but we should look at those in terms of, is it the appropriate dose and type of medication? So again, the goal of the DICE approach is to avoid knee-jerk use of medications, which causes many problems. We know that knee-jerk use of medications can actually worsen symptoms. We can get what we call paradoxical disinhibition. We often see that with benzodiazepines like Ativan. We are ignoring often an underlying cause like pain or urinary tract infection. We may cause side effects with medications like falls or worsened memory. Many of the benzodiazepines cause worsened memory, which we do not want in people with dementia. They tend to be associated with worse quality of life, and they can be associated with death. So again, we want to consider all those in our risk-benefit equation. We also want to expand the use of medications when we see behaviors to thinking about non-psychiatric medications, so pain control. There was a study in England a couple of years ago where, as opposed to using psychiatric medications, they empirically treated people with behavior for pain using a stepped approach and found that they markedly reduced behaviors in empirically treating people for pain, meaning that many of the people that they treated with empirically for pain had some underlying pain condition causing the behavior. We definitely underdiagnose pain and dementia, so it's very important to consider. We also should consider antibiotics for infections, bowel regimens for constipation, and many others that we don't largely think about when we see behavior. So again, to recap the use of medications in the different steps, we would consider psychiatric medication use at that first step of the DICE approach if there was concern for harm or risk, or the person with dementia had significant distress, such as a depression. In the investigate step, we would consider psychiatric medication use if behavior wasn't allowing us a full investigation. So the fear of aggression was preventing us from getting a blood draw or urine sample. In the create step, we would consider psychiatric drug use as first line if there was a serious depression, psychosis, or aggression with risk. And then importantly, if we use medications, we should always evaluate them, and we should never just continue them for years and years. I used to work at the VA, and one of the things I saw was that people would get started on antipsychotics for delirium when they were in the hospital, and they'd never get stopped. And I would ask the person, why are you taking that? And they'd say, I have no idea. It's just on my regimen. I keep taking it. So we always need to evaluate if medications are still needed, and for adverse effects, whether there's still risk, and whether importantly, we can taper and discontinue them, because behaviors are a moving target. What you see today, you may not see in a week. So in the last part of my talk, I want to talk a bit about how we even further package the DICE approach. And so one of the things we did in the last 2 years was we created in-person training sessions, and we piloted a day-long DICE training with caregivers. This included 8 modules with an hour-and-a-half brainstorming session at the end of the day. We did one statewide training in Wisconsin with dementia care workers from across the state. We're still working on results from that. And we did 3 large trainings in Michigan, in Grand Rapids, Ann Arbor, and East Lansing. We included both family and professional caregivers in that training, and we trained almost 200 people. And I'm going to show you the results from this in a second. So this is the DICE manual, which is actually available on Amazon, and we got funding to do that. Again, we mixed professional and family caregivers. A number of the professional caregivers were also family caregivers, so that was very interesting. And what we found was that both groups showed significant improvement in many of the things we evaluated, such as understanding the way the person with dementia interacts with others in their environment, here protecting the dignity of the person with dementia, dealing with behaviors was very significant, deciding about risk was significant in family caregivers, and offering stimulation, offering choices to the person with dementia was significant in both groups. And then significant was creative activities, understanding the causes of behaviors in family caregivers, and then for both groups, understanding how to assess and manage behaviors, and then understanding the interaction between the person with dementia, the caregiver, the environment. And if you'll notice here, the family caregivers, both groups benefited significantly, but the family caregivers even more. And we think part of that has to do with the fact that many of these family caregivers had gotten so little going into the training that much of this was new to them. And so we saw even more improvement in that group. We also did qualitative feedback focus groups with each of the groups. And these are just some exemplary quotes. One was, the whole approach organizes a complicated medical problem, brain disease, into something more manageable. Every aspect of the training was illuminating for me. I found great comfort today. Education is really empowering. The DICE approach incorporates frontline staff to help describe and investigate and be included in the process. One really poignant thing that one of the CNAs told us during one of the trainings was that they are often encouraged in their daily work to think about linear thinking, going from point A to point B, and not really encouraged to think in a problem-solving way. And so clearly, if the DICE approach is to be incorporated into a facility, it needs to have buy-in from the higher level hierarchy so that frontline staff, who often have the best ideas about how to manage behaviors because they know those patients the best, much more so than a doctor like me coming in once a month, might understand a behavior. We need to empower those folks so that they can be part of unpacking and managing behaviors. And lastly, I like the different steps in DICE and how simple the acronym is, how it focuses on the person, how to help them and the caregiver through situations rather than just accept the disease. They found among the most helpful aspects the materials, which included the case studies and role playing, talking to other professionals as well as the family caregivers, combining them for interaction and learning, the DICE framework, how we incorporated medical issues, and then that they had the manual and handouts to take home. So what we did with all that is that in-person trainings, and this was even pre-pandemic, in-person trainings are expensive to do. They take a lot of time. And so we created a training website, which is now available for everyone to go on and train. And this includes all of the modules that people got during the in-person training, and we used a lot of their feedback to improve them even further. And then at the end of the training, we have 2 e-simulation situations where caregivers can kind of go through and make choices based on what they learned in the DICE approach to sort of check their learning. And at the end of that, the person becomes certified in having learned the approach. And so I am going to just try to show you a little snippet of the website. And what you're going to see is I was volunteered to narrate much of the modules, but they also include a lot of infographics and other things as well, and e-simulations. And you'll notice, just for your humor, that I have more makeup on in this video than I've ever worn in my life, but you know, that's just how it goes. Oops. Sorry, I got so excited there. Okay, let's see if I can click this. Leah, I may need you to help me. Leah. Oh, here we go. Great.
Describe is the first step in the DICE approach. It is crucial for caregivers to describe problem behaviors thoroughly and clearly. We often miss this step because we state problems vaguely. We might jump to conclusions about the causes of behaviors, or we start to intervene with solutions right away before we really understand what is causing the behavioral changes.
Okay. And Leah, how do I get rid of it? Hang on just one second. Amazon off. Sorry about that, guys. I had behavioral issues with my Amazon right there. So that's our training website. And again, I'll be showing you a link at the end if you're interested in that. But what if for some reason training was not possible via a website for a caregiver? We've come up with another alternative, and this was the WeCare Advisor. We created this in a 3-year NIH grant. It was one of 2 awarded in the nation. It actually had 3 parts. We put a lot of thought into that. The first was a whole year of qualitative work with family caregivers of people with dementia. The second year was spent building the tool with developers and then beta testing it with family caregivers. And then third year, we did a pilot randomized control trial of using the tool versus people that didn't use the tool. And so what is the WeCare Advisor? It incorporates the DICE approach into an online tool. And one of the things we heard from caregivers was that they need information when they need it. And excuse me, I'm just going to take a sip of coffee. They need it when they need it, 24/7, for when they have 5 to 10 minutes to look something up. And so we created a caregiver survival guide that's within this tool that includes vetted medical, legal, financial, functional, and social information. This is just an example of what somebody would see if they wanted to look up what is dementia, how does the brain change with dementia. We also included, because caregivers told us they wanted this, a daily supportive or motivational messaging. And this was one of their favorite features actually during the trial. So we included this, and that's something they get either by email or text. Secondly, we know that dementia care is neither personalized nor precise. So we included in the tool a personalized peer navigator who is keyed to the age, gender, and race of the person with dementia to lead them, of the caregiver to lead them through the tool. This peer navigator also leads them through how to use the DICE approach over 5 to 6 screens. So as opposed to having to go through training to learn the DICE approach, they are led through the approach in the tool. Third, caregivers are not trained on how to use strategy. So what the WeCare Advisor does is it leads the person through the DICE approach, and then an algorithm running in the background that is based on caregiver input and research trials and evidence selects from over 1,000 treatment strategies to give that person a prescription that is for the person with dementia and the caregiver and is tailored to their situation and what they're experiencing. And so a sample prescription might look like this. It comes to the person both via the tool, as well as they can email it to themselves or others, so that everybody is on the same page, and includes the strategies that might be used for that particular behavior. So all that is great, but does it work? Yes. During brief 1-month use of the tool, we found that family caregivers had significant reductions on our primary outcome, which was caregiver distress associated with behaviors. And we chose that outcome because it is associated with most of the negative outcomes of dementia caregiving, like hospitalizations and nursing home placements. And so you'll see here that the people using the tool had this rapid reduction in caregiver distress, whereas the people not using the tool kind of hung out where they were. This is not really a significant difference. But once we gave them the tool in their turn, they in turn had a significant reduction in distress. So it did work. And we had wonderful feedback from caregivers using the tool. For time, I'm not going to read all these, but people in essence did not want us to take the tool away once the trial was over. They said they wish they would have had it earlier. In one case, we had somebody who had a UTI and was able to figure that out through the use of the tool, through the DICE prescription in the tool. So those are the approaches that we have developed. And I just want to summarize by saying that because the number of people with dementia and their caregivers is so large and growing every day, and that we really want the goal of living with dementia to be living well, currently we have systems that are inadequate and lead to poor outcomes. And so we really need more innovative solutions. And that's why we've worked on the DICE approach and the WeCare Advisor as exemplars that can put the key components of good dementia care at the fingertips of people who need it the most. And what we know with the pandemic is that these innovative solutions are even more critical right now. And we currently have a new trial that will be recruiting soon for the WeCare Advisor, where we are going to recruit nationally for caregivers and people with dementia to use the tool. We want a much more diverse sample than in the first trial. And we're going to recruit more than 300 people. So we're really excited about that. And so I hope I can come back at some point and talk to you about the results from that trial, but we're very excited for both. I just want to end with this screen, and I know my presentation will be available to all of you. Again, I don't profit from any of these. They all go back to right into making both the website and the WeCare Advisor better. The DICE manual is available online. We also have the training website up and running. We also will do, I say in-person trainings, but they'll probably be Zoom by arrangement. And then we are going to be developing certification for people who train in DICE to be able to become master trainers. So that's something coming in 2020 that we're really excited about.